This portion is going to be presented by Dr. Terry Chappell, who has, and this is an impromptu. I don't have his CV and all that kind of good stuff. He's a family practitioner in Ohio, and I wish I had a dollar for every printed word he has had published. He has written some of the most significant documents pertaining to chelation therapy and the evidence. And I believe you've got an article coming out in a future Townsend letter. Is that the next one?
May issue. Yeah.
In the May issues, that means we'll get it next month. And so he's been around the block several times, and so he's going to present the history of chelation therapy. I gave him a little bit of the history of the molecule, and I'll be interested to hear where you go from here. So without any further ado, Dr. Terry Chappell.
Got to use the disclaimer. Is this familiar to anybody? Determining that no claims are being made during this lecture. Sound familiar? Okay, here's the chelating agent, which Chuck has already been over, I'm sure, and the two forms of EDTA. Calcium, you've been through this, right? Okay. EDTA and calcium homeostasis actually was first brought to the attention. The initial work was done in Germany, where it was used as a dye. But then, as far as using it in human beings, Martin Rubin and Frederick Bosworth were involved in getting the patent for disodium EDTA, which was a very important thing. That EDTA is now used. It's still in the purple top tubes when you draw blood, and it's in cereals and the grocery shelf. So it's been around for a long time. Now, starting to use it for human beings for lead disease or lead accumulation occurred with Norman Clark in Detroit. And he happened to be a cardiologist, and he also noticed that in his cardiology patients who he was treating for lead toxicity, a number of them were showing remarkable improvements in their heart function. So he's the one that started to work on this and published its early information on that. And we call him the father of chelation, although some people call Gary Gordon the father of chelation. So there might be two fathers in there. Clark's work started in 1956, and he had 20 patients with unstable angina, 16 of whom improved remarkably. And that recovery rate of 80% or more sticks with us, as you'll see. Then in 1964, years later, he had people post-MI, and once again, dramatic improvements in vascular disease. Then in 1960, early 1960s, Marvin Seven, who was at NIH, held two symposiums on EDTA. And this is in the early 60s. He was unfortunately killed in an automobile accident in 1961, and that was the first setback for chelation therapy. Dr. Kitchell and Meltzer were cardiologists, and they started to do a lot of research on chelation, and their initial results were positive. And in fact, their results were positive, the last issues, but their conclusion was negative. It said that chelation was no better than any other therapy at that time, any other medical therapy. It's very questionable how he came up with this negative conclusion, because the results were positive. And people think that maybe there's some kind of pressure put towards them as far as not advocating it anymore. Once again, there was 71% improvement in disabling angina. The critique of that article is written by ICIM doctors Cranton and Frackleton, but it was ignored. Dr. Ray Evers, down in Alabama, near us, did a whole lot of chelation therapy. In fact, about anybody who walked through his door, he gave chelation therapy. Some of them were terminal, basically. So a number of his patients died, and he did report some complications. He was treating people who were really too sick to be treated. But he also did, he sued, and it went all the way to the Supreme Court, and that is saying that a medication that is approved for use in the United States can be used for other indications. And that's very important, and it's applicable to physicians in conventional medicine as well, and of course in the compounding world. Carlos Lamar. Carlos had many positive reports in the 1960s, carefully documented, and he wrote them up in longhand. One thing that he noted was that diabetes was particularly effective, and he's the only one that really said that until we got to the TAC trial in just recent years. Everybody else focused on circulation, but they didn't focus on treating all diabetics. Abbott had the patent for EDTA, and that expired in 1969. So we had 3 setbacks of EDTA chelation therapy: the death of Martin 7, Kitchell and Melcher's negative conclusions, and the patent running out. And a 4th one, along came what? Service. Cardiac surgery. That's when they started doing the cardiac surgery. So that shoved chelation into the back seat. A few physicians in name: Harold Harper, Gary Gordon, Ross Gordon, Bob Vance, and Dave Roberts, got together and formed AMPS. This is the American Association of Medical Preventics. Later, the name was changed to ACAM. They started presenting workshops and teaching other doctors how to do chelation therapy, and their work continued on. One of my medical heroes was Linus Pauling, and I did get the opportunity to meet and have lunch with him at one of the meetings, one of the ICIM meetings. ACAM also made Linus Pauling a lifetime member, and he spoke several times advocating the high-dose vitamin C, along sometimes with lysine and proline, particularly in people that are high risk with Lp(a). So that was his key work that still is listed today. And Denham Harmon, back a little bit further, first proposed the theory of free radical damage. And of course, that's the main mechanism by which we think that chelation works. Hi, got a nice echo sound. Can you still hear me okay? Okay, I'll go right through it. Tamburino and colleagues reported later on that osteoporosis might improve with chelation therapy. That buzz, I don't know. Okay, Bloomer and Wright. Bloomer was a physician in Switzerland, and he was doing research on chelation, treated a lot of people on chelation. But they showed improvement, and he was right near a highway where there was still lead in the gasoline, and that's one thing that he was looking at was lead toxicity. But looking back on it, he had over a 10-year period, the incidence of cancer was reduced by 90%. Now that report has never been duplicated. Nobody's ever tried to duplicate it in print anyway. But that's a real eye-opener to think that maybe we're dealing with cancer as well as vascular disease. Borgstein published theories on life extension and using chelation therapy in the early 1980s. In 1976, Gary Gordon and Robert Vance, two of the early pioneers, if you remember, wrote a paper on the possible mechanisms of EDTA chelation therapy, and they listed many mechanisms that could come into play. Free radical damage was one of them. Dr. Bruce Halstead in 1979 wrote this textbook. It's an amazing textbook with just beautiful pictures demonstrating how free radical damage can occur and could be corrected with chelation therapy. Dr. Ted Rosema back forward in 1997 updated that and added about twice as many pages, and that's still a classic. Dr. Richard Krasdorf was a cardiologist, or is a cardiologist, and trained at the Mayo Clinic. And he was the first one that did vascular studies on chelation therapy and proving that you can improve the ejection fraction. He also showed that you could improve brain function with chelation therapy. Those were not large studies, but they were truly significant. Ed McDonough and Charlie Rudolph enlisted the help of Taraskin. Taraskin was a researcher, and he was very good at organizing data. But Rudolph and McDonough had a very busy practice out in Kansas City, Missouri. And they kept records. They kept detailed records. So, and they hired Taraskin to write papers with them full time. And they came up with 30 papers documenting all sorts of actions with chelation therapy. And they were published and distributed widely in the holistic field. Some of them were on lipid metabolism, like cholesterol and so forth, so the carotid artery blood flow, they had a nice one with that. The lung function showed improvement with chelation therapy. Now, these were not double-blind crossover studies, but they really covered the material. And that Charlie Rudolph is the second one to retire recently, but his practice is being taken over, and that collection of papers is available from their practice. And around early 1980, the AMA said, okay, you guys advocate chelation therapy. If you really think it's worthwhile and it works, then it's your responsibility to do a study to prove it so. Well, the problem is that most people with chelation therapy were clinicians. They're not research doctors. So they couldn't afford a huge double-blind study. Finally, Ross Gordon went to the Army, and he found that there was some interest with the Army to study peripheral vascular disease. There were a lot of the soldiers had circulation problems in their legs. So they agreed to do the study, and they funded the early part of it. The study started, and then along came the first Persian War, the Gulf War. And all the doctors at the Army hospital were sent off to the Middle East, and then nobody's left to do the study. And then when the doctors came back, they went to different places, and the whole thing fell apart. And so that study was not completed. And it was never to the point where it could be published. However, several medical schools got interested. University of Michigan had some interest. That faded away. University of Kansas had some interest. I went out there with Rudolph and McDonough, and they looked like they were going to do it, but then they didn't. And University of Washington out in Washington State came so close that on the day they were supposed to submit their application for funding, they were all set with a letter to go out in the mailbox, and the dean of the medical school came along and said, "We're not doing this, no questions asked," and threw it in the wastebasket. Obviously something happened at the last minute here. It's just, that's the type of things that we faced in trying to get this study done. Several conventional doctors wrote critiques of chelation therapy. On the other hand, the American Board of Chelation Therapy, and then later the American Board of Clinical Medical Toxicology was formed, and that formed to certify doctors so that they could say they have an extra credential to say that they're really doing a professional job with the chelation therapy. The Great Lakes Association was formed in 1983 by Jim Nutt. It was originally a obesity group of doctors treating obesity, and they had got together yearly, and then they decided to form a broader organization. That was called Great Lakes, and now that is called the International College of Integrative Medicine, which we're here for today. Elmer Cranton wrote the book Bypassing Bypass. That's a wonderful title, and it became a popular book, and he made the case for chelation therapy very effectively. He is still alive, but he runs a blog out in the University of Washington. He was a Harvard-trained physician. Frackleton, along with Cranton, Jim Frackleton in Cleveland, wrote a paper on free radical etiology of illness. And that was a classic description of the free radical damage and the diseases it can lead to. If you can get a hold of that paper, that is really one that is an important one. International Society of Chelation Technicians was formed in 1983. Robert White was the first executive director, and that was just like you're doing. They came together and learned about the best ways to provide chelation therapy and support the physicians. That organization, though, is no longer in place. And ICIM also had similar training courses. Barb Grunwald was the first one to do it for ICIM with Al Scarcilli's practice in Detroit. My nurse, Marcia Arnold, took over after she did, and we've had others do the same. So that's very important to us. 1987, there's an organization formed, the International Biooxidative Medicine Foundation. Charles Farr was the first director and was the first chair. Here's the Walter Reed Hospital that I mentioned. Ephraim Olzaware and James Carter. Ephraim is a cardiologist in Brazil, and he wrote many papers. He was very prolific, and he did several big studies. One of the studies he did along with James Carter, who was on the faculty at Tulane Medical School. And together they did a study that looked at various forms of vascular disease and showed that they could improve vascular disease. However, there were no controls, and it wasn't double-blind. Except one of their studies, a very small study, was a crossover double-blind where they treated 5 patients with placebo, 5 patients with EDTA, and then they crossed them over, and only the ones that were treated with EDTA at the time improved. The Journal of Advancement in Medicine was published for about 11 or 12 years. The editor of that journal was Derek Lonsdale. Sorry about that. Derek was an amazing physician. He was on the faculty of Cleveland Clinic. He's a pediatrician. And he was very much dedicated to publishing articles about alternative medicine, and particularly with chelation therapy. And if you ever went through submitted a paper to Derek Lonsdale, you knew it was coming back with red lines all over it. He was very, very strong in saying that you want to write this well and you want to present your arguments well. He's very good. He's still alive, still sends out letters every now and then. I think he's about 92 years old now. He's a wonderful man. At ICIM, we did an institutional review board to help physicians get their papers published and to help certify them. We ran that out of my office, and we had meetings here, and physicians who wanted to present the research came to us and presented it, and then we voted on it, and if they were approved, then they were much more likely to be published. 1990, Robert Rowan persuaded the Alaska state legislature. He was, one of his patients was the governor of the legislature, or governor of the state at that time. And that was the freedom of choice in alternative medicine. So that patients should have the opportunity to choose whether they want to have alternative medicine versus conventional medicine. Just in the last few years, that's come to conventional medicine because it's patient's choice is considered to be an important aspect of choosing which therapies the patient receives. It still isn't widespread in its action, but it's there and present, and it's been published in all the major journals. Popular books on chelation therapy during this time: 40-something Forever by Arlene Brecker was a very popular one. Morton Walker wrote The Chelation Way. He actually wrote several books on chelation therapy for the public, and they were really helpful in making chelation popular. James Carter, as I said, he was from Tulane University on the faculty of School of Public Health. He wrote an amazing book on racketeering in medicine, showing how in medicine the powers that be were working against alternative medicine and trying to make it unavailable to the public. In the early 1990s, there were 3 small conventional studies that were critical of chelation therapy. It's interesting that all of those showed slight improvement, but they didn't show big enough improvement to have statistical significance. And one of the reasons they didn't have big enough proof was because they didn't have enough patients in it. But there are some very serious defects in all 3 of these studies. One of them, I worked with Michael Godfrey in New Zealand. One of the studies was done in New Zealand. And that study had 15 patients in the control group and 15 patients in the treatment group. And they showed that chelation therapy didn't have any benefit for that. However, they didn't show how the patients did in each of the individual cases in the study. And they wouldn't release the data. And Godfrey and myself tried for several years to get the original data in that study. And finally we got it. And there was one patient in the placebo group that was far and away improved, much more than anybody else in the whole study. Completely skewed the study. And it didn't show, if you excluded that patient, it showed that chelation was very effective. That was the type of thing that we were faced with. Another thing was, in Denmark was another group of studies, and it was actually run by a resident. And in that study, there were many things wrong with it, but one of the things they did, and this was in a double-blind study, they just put the solution up on a shelf on a bookcase, and the patients were instructed to go get their IV and start it themselves. And that was the control. There was no control over it at all. And then they just came back and checked off what they had and so forth. That study, Dr. Hankey, who is a chelation physician, I'll mention him in a minute, he sued these physicians, they're cardiovascular surgeons, and said that they were falsifying their data. And Dr. Carter and myself were expert witnesses. So we went over and we testified. It went all the way up to the Danish Supreme Court. And we testified before the Danish Supreme Court. I was a little handicapped because on my way over, my eardrum broke. And the person who translated was on that side of me. So I couldn't hear very well. But as it turned out, they found that the study was a fraudulent study, but it wasn't bad enough to take the licenses away to the physicians who did it. So we won the case, but we didn't win any big prize. This is Dr. Hankey from Denmark, and he did a separate study. They had socialized medicine there, and 65 patients were on the waiting list for bypass surgery. There's a long waiting list because of the socialized medicine. So he went ahead and offered to chelate those patients for free to see if we could prevent the bypass surgery. And only 7 out of those 65 patients then had to have surgery after they had chelation. So it's a tremendous improvement. And he also took patients that were on the waiting list to have amputation, their lower legs chopped off. 27 were scheduled for amputation, and only 3 had to go through with chelation after they had chelation therapy. And this was published. He also did a retrospective study of 470 patients who received chelation therapy, and the vast majority of those also improved. Once again, in the neighborhood of 87 to 90%. We did a meta-analysis. One of my patients happened to be a statistician. And he said, "What? Have you ever done a meta-analysis?" This was when they first started doing meta-analysis, which is a study of studies. And I said, "Well, no, nobody's ever thought of that." So what he did, he said, "Well, let me help you." So what we did is we gathered all the published studies that we could find that showed the results for individual patients. And we put them into a big statistical pile called the meta-analysis. And when we did that, we came up with 0.88. There was a 0.88 correspondence or correlation between treatment of EDTA and measured improvement in vascular disease. A perfect score would be 1.00. So 0.88 was a very high correlation. And it turned out that about 87% of the patients in the study had showed measurable improvement. We also published this in a book that was for patients, and we also went through and did another meta-analysis in unpublished data using the same criteria, and the results were almost identically the same. This was easy for me to write because my patients wrote the questions and all I had to do was answer them, and it worked out pretty well. Escobar showed improvement in 76 out of 80 patients. This is 1995. Huckstra, and this is Phil Huckstra, the third, and he was carrying on his father's practice of thermography. And using thermography, he showed improvements in circulation, particularly in peripheral vascular disease and some in carotid vascular disease. Dr. Michael Jansen and myself wrote an article in a nursing journal that was published. This is indexed. A lot of the other studies had not been indexed, so that's one reason why that was significant. I'm going to check to see how I'm doing here. Okay. Martin Rubin, remember he was the one way back in the 1950s that first got a patent on it, late 1940s. He published in the Cardiovascular Drug Therapy in 1996 a chapter on magnesium EDTA chelation therapy. First time it had got into conventional cardiology textbook. Michael, who was responsible for many of these slides, Michael Schachter, wrote a history of a historical overview of chelation and of ICIM at that time. And he also, along with Ted Rosenman, published the protocol that was generally accepted for physicians. Quackbusters. These are the enemies of chelation therapy, not just chelation therapy, all alternative medicine. Victor Herbert, who is deceased, Stephen Barrett, still alive, but doesn't have a license to practice medicine. Attacked many doctors, made complaints to medical boards, and so forth. They infiltrated the Federation of State Medical Boards and encouraged disciplinary actions against chelating physicians across the country. A lot of legal bills went to defend the doctors in this. Although the doctors usually won, it was very difficult to raise the money required to get the attorneys that they needed. One of the complaints was made to the California Medical Board, and we actually, there were two doctors, myself and Ralph Miranda, testified defending chelation therapy in a hearing to the medical board. There are about 25 people on the medical board, and they gave presentations, the opposite view, and we gave presentations. We won that. They took a vote, and we won it by one vote. Otherwise, chelation would have been outlawed in California at that time. The Federal Trade Commission listened to the quackbusters. The Federal Trade Commission got a brochure from ICIM that had said basically chelation therapy is effective in treating vascular disease. It is safe. That's all it says. It was written by Elmer Cranton. And that one brochure was enough for the FTC to take action against ICIM, saying that was making an illegal claim, and the only reason you could make a claim like that would be a big double-blind crossover study. ICIM defended that. It was sent in 100 articles showing the effectiveness of chelation therapy, but no big crossover double-blind studies. Fortunately for ICIM, they had some money in the bank, and the exhibitors provided most of that money. Ed Shaw was the executive director, and he made sure the exhibitors paid. ICIM spent $1 million in legal fees defending that claim. And finally, the FTC didn't give up at that point. They said, you gotta go further. So finally, they negotiated. ICIM said they wouldn't make the claim anymore. And the FTC said, okay, but we'll be watching you for the next 10 years. Make sure you don't. So ICIM survived, but it was a $1 million lesson. That's why I made sure that I said no claims for this lecture, right? Okay. Okay, 2003, we're getting into the 21st century here. Dr. Lin and Lin Tan published a double-blind study using calcium EDTA treating people with kidney disease, mild to moderate kidney disease, and they showed that there's a good percentage of the patients improve their kidney function after being treated with chelation therapy. Now, we always watch kidney function because we want to make sure that we don't overload the kidneys, but if you watch it carefully and you monitor it carefully, sometimes you can improve kidney disease in these patients. Stephen Olmsted. Stephen wrote a monograph. He was the one at University of Washington, by the way, that was submitted a research project that was axed by his dean, the president of the medical school. This was a very thick, it was about a 150-page monograph going into every detail about the chemistry and the history and the studies that had been done. And his conclusion was that the peripheral vascular disease, there was enough evidence, sufficient evidence to show that chelation might be effective, and that there possibly was for heart disease. There wasn't yet enough for carotid disease. The preponderance of that evidence showed that. That article, that magazine was then published, but it was supposed to be sent out widely to the public and so forth. They did send out a copy to every medical school in the country, but that was it. And then the funding dried up, and nobody was able to publish it anymore. So that it's a classic. It's a very, very very well done. Dr. Olmsted is a research cardiologist, but not much happened with it. What did happen, Congressman Dan Burton pressured government agencies and finally held a hearing before it was in the Oversight Committee, a congressional hearing. And at that hearing, he invited the chelation doctors. The reason he did this, by the way, is he had a grandson who had autism who had been really helped with chelation. But anyway, I was participating in that. Dr. Ted Rosema and I and Dr. Marcelo Vega, three of us, testified in favor of chelation therapy. And then Burton called in the people from NIH and said, "Why are you doing research on this?" And he had the head of NIH and cardiorenal in there. And actually, they gave their testimony first. And they got up to leave, and Burton said, "No, you guys are not leaving. You're going to sit here and listen to what the chelation doctors had to say." So he made them sit through all the things that we had to say. And then as a result of this, he pressured the NIH to send out a request for proposals so that they would fund a big study on chelation therapy. So that happened another year or two later. And they submitted the request for proposals. And then they had NIH had an evaluation hearing, which they always do for proposals that they're going to possibly fund. And I was asked to be on that committee to listen to the proposal. I was the only chelating doctor to be there. There were about 25 doctors in the room. And they presented the article and everything. And then they went out of the room, and then the head of the evaluating committee said, "Okay, we're going to go around the room and everybody give a score of what they think this research should be from 0 to 10. So they started, I was in the middle here, and the guy to my left was the first one, and they went around the room, so I was the last one. And the scores were like 3, 4, 2, 5. I don't think there was any above 5 till mine got around, and I thought it was a good report. So I said 9, So I said, okay, we'll put this to committee further and look at it. So it didn't look very promising at that time. Until afterwards, the guy who was the head of the committee came over to me and said, "I can see you're pretty upset by what happened here." And I said, "Yeah, I sure am." And he said, "Don't worry, we always fail them the first time through." So that felt a little better. So they sent them back, and they asked for further revisions. And it came back to another committee. And this is a different committee. It was a different one, except I was asked to be on it again, but nobody else was duplicated. And it was more like about a dozen physicians. Some of them were practicing, some of them, they were all connected to medical schools in one form or the other. This time, I was the first one to give the score. So I thought, I'll at least give them an 8 to give it, not seem like I'm overdoing it. They went around the room, and everybody else gave a score higher than 8. I was the lowest score in the room, so they approved it. And that was a $30 million study to study chelation therapy, thanks to Dan Burton. And he was in Indianapolis, by the way. Dr. Tony Lamas was the chief investigator for the trial to assess chelation therapy. And he's a cardiologist researcher. How are we doing for time? You okay? Okay. Who has published some very significant articles in the medical literature. He's very well respected and connected all through the cardiology community. And so he put together the trial to assess chelation therapy. And there were cardiologists in the trial, and there were practicing chelation physicians in the trial. But it was done by the book. It was double blind. There was no question about it. You got each person's treatment solution came in the mail that week, labeled and everything. And then you had to complete the chart and all the physical signs and all the reports from the patients and so forth. And you had to complete that record before they would send you the next bottle of solution. So it was very well done. The only trouble is it was a little difficult to enroll patients because this is a double-blind study, and that means that there's half of the people got placebos, and they were getting 40 treatments, 30 for basic course and then 10 more at monthly intervals. So he wanted to really test and evaluate the treatment. So it was a little difficult to enroll patients, and it took longer to do so than expected. Coming up. Our office participated in that, by the way. It was projected to be a 5-year study. It turned out to be much longer. Adverse events were monitored very, very closely. Other TACT is called TACT, Trial to Assess Chelation Therapy. Many cardiologists discourage their patients from participating in the study. They said, "Don't do it; it'll kill you." The prejudice was really dramatic. The enrollment proceeded slowly. The quackbusters complained. And when there's a complaint for a study like that, the government has to halt and investigate that study. So that stopped the study for about a 3-month period. And nobody could continue to give treatment during that time. But what happened was, because they stopped the study, they were able to follow the patients for a longer period of time, and they didn't need as many patients to enroll that way to get statistical significance. So instead of 2,000 patients required in the study, we only needed 1,700. And so that made it easier to complete the study, thanks to the quackbusters who interrupted the study and made us delay it for 3 months or so. During that time, right about the time of the study, there was some bad publicity because there was a child who died of chelation therapy. This is an autistic child who actually had physician parents. And the reason the child died is the physician who was treating autistic patients for chelation therapy, but he called up another doctor about it. He didn't have any experience or training on it. And what happened was he gave the disodium EDTA by IV push instead of the calcium EDTA. You can give calcium EDTA by IV push. You can never give the disodium for EDTA because that drops the calcium, and that can cause a critical arrhythmia. And that's what happened with that child. So the FDA investigated it and so forth. They came to the conclusion it was the wrong solution was given. But whatever you do, if you're giving both of those therapies, the calcium EDTA oftentimes is given as a challenge test to see if there's toxic metals. And some people give it as a treatment for toxic metals. But it's not approved for vascular treatment. All the vascular studies were done with disodium EDTA. So be very careful. If you have 2 of them in your office, put them on different sides of the room or something so you make sure not to get the wrong solution. Okay, the results of the TAC study were given on November 4th, 2012 at the meeting of the American American Cardiology meeting. And the results showed statistically significant benefits for the people that got chelation therapy. The paper was published in the Journal of American Medical Association on March 27, 2013. Statistically significant subgroups involve diabetes and the location of the coronary artery disease being the left main artery, which is the worst one. The conclusions of TACT by Dr. Lamas were that EDTA chelation appears to be safe. The treatment and the study showed some evidence of benefit for post-myocardial patients. Everybody in the study had had a previous heart attack, so this was secondary prevention. The findings were unexpected, and additional research is needed to confirm or refute our results and possibly explore mechanisms of therapy. He had to put that down because the cardiology community was unexpecting these results for sure. And they always want one to confirm, they say. That doesn't always happen. TAC does not constitute evidence enough to recommend the clinical application of chelation therapy by itself. We'll get to more of that later. Actually, the article that Chuck mentioned that's coming out in the May Journal that we wrote was saying that it was exploring the status of chelation therapy in conventional medicine and what it should be based on the results we have today. And I have in that article explored about 10 studies that have been written in major cardiology journals and published in major journals in the last 2 years since the TAC trial. So it'd be if you want to defend yourself or you want to justify it to local cardiologists, I suggest you copy that and the references because that could be very useful. The main criticism of the study was that greater than 60% of the sites were run by integrative practitioners, but actually the studies that were done in cardiologists' offices did a little better than the ones that were done in the chelation offices, which was interesting. This is Dr. Neeson, and he's at the Cleveland Clinic. And in the JAMA article about the results of the chelation therapy, he was invited to write a rebuttal. So he's an anti-chelation therapy doctor. He's been anti before. He's written editorials before. Maybe head of the next FDA. I don't think he is still in contention for that. Here's the lead quackbuster, probably David Gorski from Wayne State University. Got his initial fame with anti-vaccines. Now, in 2005, while the TAC study was going on, myself and 7 colleagues got together to publish a retrospective study showing patients with known cardiovascular disease treated with EDTA at a much lower incidence of cardiac events. And that's heart attack, need for surgery, need for bypass surgery, death. Those are the same cardiac events that the TAC trial used. But it wasn't a double-blind study. But what we did is we found matched controls in the literature to see how they did, and we compared them to the results we had. And the results were much better with the chelation-treated patients. Okay. This is the result of our retrospective trial compared to the TAC trial. And you can see that there's a lot of good comparison here. The age, previous cardiac surgery, actually the TAC patients were a little sicker. But when we go down here, as far as the deaths go and the heart attacks, there weren't any. Out of 220 patients in our study, we didn't have any. We had some that had required surgery. But of course, there were a fair number of predicted deaths and heart attacks and so forth in the TAC trial. Possible reasons why our study may have turned out with better results. First of all, the TAC group were at more severe risk. Secondly, the retrospective group received on an average almost twice as many chelation treatments. I think that's important because it shows that maintenance is important. Okay, it's not, you don't just treat the patients and forget about them. Although in the TAC trial, you'll see in a minute how that turned out. Probably there's more emphasis on nutrition. I'm sure there's more emphasis on nutrition and lifestyle changes in the chelation group, and more supplements were given, obviously, that way too. Okay, what are the mechanisms? You can look this over. Increase oxidative stress, promote inflammation. These are toxic metals. What do they do? These are some studies that have appeared since the TAC trial on the toxicity of heavy metals, particularly for cardiovascular disease. In that article that's coming out in the Thompson letter, all the references will be listed in there, so you can get them there. Just to show it, how the TAC trial did it, they were in 4 different categories. There were actually 2 placebos and 2 treatment groups. There was a chelation treatment group, and there was a high-dose vitamin group versus placebo vitamins. So the biggest placebo group had neither chelation or high-dose vitamins. The most effective treatment was in the group that had chelation therapy and high-dose vitamins. So the high-dose vitamins by themselves were not statistically significant, but when you put them together with a chelation group, they increased the effectiveness of the chelation group. In the diabetic patients, that meant that the IV chelation group plus high-dose vitamins in diabetic patients in a 5-year study showed a death rate of about 51% less than in the chelation group than in the placebo group, the double placebo group. Okay. This just shows the placebo and the chelation group were similar groups. And similar, interesting enough, the LDL was 87 and placebo. I thought it would be higher, and 90 in the placebo group, but they weren't. So conclusion of TAC, EDTA-based chelation therapy reduces the combined cardiovascular events in post-MIA patients. The 5-year number to treat was 18. The 5-year benefit in statin drugs is about 18 for prevention. Okay, means you have to treat 18 patients to save 1 event. High-dose oral vitamins and minerals demonstrated an 11% reduction. Conclusion 3, compared with optimal medical therapy, placebo. I went through this. Oh wait, no, wait a second. Okay, if you're treating diabetic patients with vitamins and chelation, the number needed to treat is only 5. That is very low, very impressive statistically. Okay, I'm going to go on this one here. Conclusion 4. Yeah. Okay, here you can see the chelation group and high-dose vitamins versus the double placebo group. And you can see, and on the lower graph, the improvement is not only improved at the beginning. This is the number of months where they followed out. They were only treated during the first 18 months. So there was a little difference in those first 18 months, but as it goes out, it gets more and more and more, even though they did not get maintenance therapy. So if you get maintenance therapy, that's going to spread even further apart. That's my conjecture. There's no proof of that. Okay. The other thing is they did not check hemoglobin A1C on the either of the patients. They did check the fasting blood sugar. There was a minimal improvement in that, but there was some improvement in it. In TAC2, they will check that. So, as Dr. Lama says, we're at a crossroads. Number one, we have to consider the concept that environmental pollutants are a modifiable risk factor for cardiovascular disease. We have to replicate the studies with the population. Now, in the new study, TAC2, which started, by the way, in October of this past year, in the new study, it's just diabetic patients, just the ones that did the best. And they also have to have a prior MI, which they did in both studies. And they're also working out the mechanisms, doing more studies on the mechanisms, particularly having to do with the metals and how big a play that makes. Here you see in the bottom, diabetes, the primary endpoints, EDTA plus high-dose vitamins, 51% reduction in the death point. See that p-value? 0.001. How many times do you see a p-value like that? And here are the references, some of the key ones. If TAC2 affirms the result of TAC, chelation might be indicated for all diabetic patients. This is what has been suggested by Dr. Lamas to me for secondary prevention. However, what does this do? Medicare and insurance, they may not pay for non-diabetic patients because the diabetic improvement kind of carry the show. So we'll see on that. Do we want to, of course, we want our patients to do better. Will Medicare cover chelation therapy and pay $15 a treatment? I don't know. The other thing that's happened recently is that the American Heart Association and the American Cardiology Association together form levels of evidence. And just recently, they upgraded the level of evidence from a class 3, this is on chelation therapy for vascular disease, from a class 3, which basically means that there's no proof for it, to a class 2B, which shows that there is significant evidence that it might be effective. So that's big because 95,000 angioplasties were performed last year based on that level of evidence. So we're in the same category anyway of conventional medicine being in class 2 in a much, much better position. And that's what I was talking about with patient-shared decision-making. What is the standard of care now? The standard of care is shared patient decision-making. So that means that people who have evidence or therapies that are in the evidence class 2B are in the area where all the cardiologists are supposed to be explaining to their patients that chelation therapy is an option. I'm not sure they're doing it, but they're supposed to be. Okay. Sodium magnesium EDTA requires a compounding pharmacy. TACT was funded by NIH, not by a manufacturer. This is a big plus for chelation because it wasn't, they didn't have any axe to grind or any profit to make with a patent. Dr. Lamas was an independent investigator who didn't have an opinion one way or another prior to the study. The results of TACT were unexpected, so it wasn't something we were proving that we already believed in as a whole study anyway. 55,000 IVs were given. That's a lot of IVs. And the safety, there were no unexpected, there was one unexpected event in the placebo group and one unexpected in the treatment group. Tiny, tiny. Calcium EDTA, orally, only 5% has been absorbed. calcium EDTA removes toxic metals, but it has not been studied as far as treatment of vascular disease, except that one study on the kidneys that I mentioned before. It might be useful for prevention if you already have vascular disease, you know you have toxic metals, only 5% absorbed. If you eat something with toxic metals in it, well, that means 95% is going to go out through the bowel movement. So that might be a good preventive thing to do orally. Obviously, calcium EDTA does not decalcify arterial plaque because it has calcium in it. It's not going to pull out calcium if it already has calcium in the solution. So metal toxicity is now considered to be a clinical diagnosis supported by lab work, although we really tried hard for them to convince them to include a challenge test for metals in TAC 2, but they wouldn't do it. They're still looking at the blood. They looked at the blood on 20 patients only in TAC 1, but it wasn't enough to say anything about it. Well, except that in those 20 patients, there was a much higher level of lead in the treated group than in the not treated group. The future begins now. We should establish ourselves and our physicians out here as experts in metal toxicology. There's enough information out there that we can do that. Some have suggested we send a list of the references that have come, especially the ones since TAC 2, and the web address, not making any claims, just presenting the literature. Dr. Dooley out in New Zealand and in Florida has sent this out to cardiologists saying, we will pay you for the initial treatment for evaluation and the treatment after the testing after the treatment is done. It's an interesting concept. Here's a couple of websites you could check out. And the Townsend letter. If you can't find it, I guess they're going to put my picture on the cover, so you got to try to recognize that. Okay. There's a couple things I wanted to mention that I didn't get in the slides. I apologize for, but I didn't. Anyway, we didn't mention some of the role of women in this, and women, I think, have played a very significant role, particularly in ICIM. Tammy Bourne, her husband died right after they produced some research that was very important research because it reaffirmed that the results in Brazil and some work that I've done, that you can get as good results with the 1.5 gram bottle as you can the 3 gram bottle. The results in vascular treatments or vascular testing were the same. So that was important. But Tammy came to this huge clinic that they had in Grand Rapids, Michigan, and they put in a huge facility, a $4 million facility, and her husband died just as she was to move into the facility. And she took it over and continued it, and then she became representative to the Osteopathic Board of Medicine in Michigan. So she went to the Federation of State Medical Board meetings where the quackbusters were complaining about chelation. She was the only one to stick up for us, so that's pretty courageous. Robin Sika, president of this organization multiple times, and had a lot of legal trouble. By the way, the legal trouble we've had has been, not the trouble, the advice and support we've had in this organization has been tremendous. You're going to hear more about that. And he's probably going to soft-pedal himself, but Al has saved the professional lives of many, many doctors in our organizations and across the country. Jeanette Soriano kind of picked up the ball in Canada, and we have an active organization in Canada. Jeannie Driscoll on the faculty of University of Kansas has printed a lot of information on chelation as well as vitamin C, high-dose vitamin C for cancer treatments. Peter van der Sar, you don't hear much about him in this country, but worldwide, he has taught more doctors than any other doctor in the world, I'm sure. And he's written a textbook several inches thick documenting every aspect of chemistry you can think of about chelation therapy. Peter van der Sar, he's from Holland, and he's a cardiovascular surgeon. Okay. And thanks greatly to our exhibitors, our executive directors, Wendy, I kind of favor myself, and Dee Rogers are particularly ones that have been outstanding directors for quite a long time, and we never would have made it without them. Any questions that you have? I don't know, how we fix for time? You got